Thank you to Kath for inviting me. As Kath says, this day represents a hallmark in the evolution of our ability to disseminate information about the treatment of epilepsy, specifically dietary therapy. Now, the challenge for me this morning is to try and, for a spectrum of people who range from patients and parents and families to healthcare professionals, to try and, in 15 minutes, just tell you a little bit about the science of that lies behind the ketogenic and the modified Atkins diets. But just to take you back a step, in our armamentarium for treating people with epilepsy, we really, in principle, only have 4 modalities. And those are, as many of you know, medications, and for selected people, operations, for very selected people, the vagal nerve stimulator, and then more recently, there's been very good scientific evidence about the treatment with dietary therapies of people with epilepsy. The lay press is replete with articles and talks from all sorts of experts and pseudo-experts, and a lot of this is, unfortunately, hocus pocus. And a lot of dietary therapies for so-called medical conditions are led by people who are pseudoscientists, people like Patrick Holford, etc. But what I want, the take-home message today is that when it comes to dietary therapy for people with epilepsy, there is very solid science that underpins this therapy and our recommendation to use this therapy. And I think more than anything else, I want to leave you with that message this morning. And I'm going to take you through a bit of the science that we have at our disposal. Science can be a bit boring, but for us academics, it's very exciting. And so what I'm going to try and do is, in a very short space of time, just tell you a little bit about the science, the scientific evidence that we have in recommending dietary therapy for treating people with epilepsy. Because this is not pseudoscience. There's, as I'll show you in a moment, very solid science. So I'm going to start off by showing you what I consider a landmark study that appeared a few years ago and was published in a journal called Lancet Neurology. Now, there are so-so medical journals, and there are journals that are of high quality. And some of you may have heard of the Lancet. The Lancet certainly doesn't take nonsense when it comes to science and scientific publication. So this was a landmark study. And when it comes to scientific evidence, the best scientific evidence that we ever have at our disposal are so-called randomized controlled trials. And what makes randomized controlled trials very elegant is that you have a group of people who have a particular condition, and you treat them with half the patients you'll treat with a particular modality, and the other half will not receive the modality. And the difference that then emerges between the two groups represents the so-called treatment effect. And that then proves to us that you have a benefit related to the treatment and not a change in the condition. As we know, epilepsy is an ever-changing condition for many people and for groups of people. And so if you have two groups of people and you treat half the patients with one modality and the other half, you don't treat them with that modality, if the groups are the same, then the difference is attributable to the treatment. So that's why we do these things called randomized trials. Random means that half the people are randomly assigned to the one group and the other half randomly assigned to the other group. So this is what this group in London did, and this is the study that was published. And you'll see here it was entitled Ketogenic Diet for the Treatment of Childhood Epilepsy, a Randomized Controlled Trial. And I'm going to just show you what they did, and I want to show you the difference that this treatment made for these groups of children. And they were groups of children. So starting off here, you'll see in yellow there, they recruited kids from, this is in the UK, at Greater Ormond Street. And these doctors here see kids who represent the most severe forms of epilepsy in the UK. So these are not kids with mild forms of epilepsy. And that's the first take-home message. And we know that when seizures are particularly bad, when they get referred to these doctors, they usually represent kids who failed medical treatments. Then you'll see that they're aged between 2 and 16 years, and Importantly here, these kids were having seizures every day. So these are frequent seizures, and it just makes the point that these are the most refractory, medically refractory, in other words, those that don't respond to medicines of patients in the UK. And then they hadn't responded to at least 2 anti-epileptic drugs. A number of these kids had many more medications tried. And then you'll see there in yellow, they were randomly assigned to groups by use of a computer program. So this is high-quality science. And what they did was the children either started the diet immediately, or should I say after a 4-week run-in period. And the baseline period there was to ensure or to record the frequency of seizures in these groups of kids who were either going to get the treatment or who weren't going to get the treatment. So you had some idea of what their natural seizure frequency was on their existing medications if they were taking them. Not all of them were taking medication at the time, because in some instances the seizures just did not respond at all to medications, and that does happen. So then 4 weeks everybody is observed, and then half of them are randomized to the diet, the ketogenic diet, and the other half continue as they were as before on their medications, or as the case may be, without medication. And then within this trial, because they were interested in the ways of doing the trial, half of the kids who got the ketogenic diet got MCT oils, and the other half got the classical version. And Kath will talk to you a bit later about that, I'm sure. Of course, when you're doing a diet like this, you can't blind people like we do with medications, give them placebo tablets. So that's a minor limitation of the study, and at the end of the day, it really didn't materially influence the results here. When people are blinded, that ensures that there's no bias in terms of reporting of seizures, but the treatment differences were so big that we needn't concern ourselves with that methodological issue. So then you'll see here that the patients were then followed up, and what happened was that everybody was followed up for 3 months, and the reason it was only 3 months was because ethically they couldn't indefinitely continue not giving half the kids the ketogenic diet. So the trial only lasted three months, so there are limitations in terms of understanding what happens beyond that from the study, but nevertheless, we have very good data in terms of what happened in that time. And so what they looked at was a decrease in the frequency of seizures. That was really the outcome of interest. But like all trials, they also measured adverse effects or side effects, because any intervention potentially might have adverse effects. And they did that in the study and recorded those. Particularly the known ones are things like constipation and nausea and vomiting, etc., diarrhea. And the parents and the families were then asked to record seizures daily. And importantly, they, unless it was a medical emergency, medications were not changed in this 3-month period. Of course, if the need arose and it was a medical emergency or urgent at the discretion of the individual, this could be changed. So that's the method. And you will see there in blue they had 37 children in the diet. In the diet group were assigned to a classical ketogenic diet, and 36 to the ketogenic diet. So 70-odd patients in each arm of the trial, diet and no diet. And you'll see there, as I made the point earlier, there were 6 children who were on no epilepsy treatment whatsoever. And that just reflects the fact that the doctors and all the patients or everybody agreed that the treatments were having no beneficial effect, and so they were stopped. And we do need to do that sometimes. At 3 months, in terms of looking at seizure freedom, in other words, cessation of all seizures in 140-odd patients, 70-odd in the dietary group and 70 in the placebo group, as it were, there was only one child who was free of seizures, and predictably that was a child who'd received the diet. So the point being that occasional patients become seizure-free, but the vast majority in a group of kids who have the worst forms of seizures in the UK, these are not mild seizure problems, these are bad seizure problems. One out of 70-odd children became seizure-free. So that, in a sense, is remarkable because medications didn't do that. The best treatments that they could throw at them didn't do that. And just to make the point about what sort of forms of epilepsy these kids have, some of you won't know these names, but those of us who work in the field and will know that conditions like Lennox-Gastaut syndrome, West syndrome, myoclonic absence epilepsy, and myoclonic astatic epilepsy, these are some of the most difficult to treat forms of epilepsy that exist. Now, when it comes to the efficacy of treatment, you will see here in yellow on the left is the diet group, and on the right is the control group. And these are percentages expressed as in respect of the baseline seizure frequency. So you'll see the patients who were put on the ketogenic diet, the seizure frequency dropped to 62% of the baseline. In other words, a 40-odd% reduction in the frequency of seizures, mean seizure frequencies. Whereas in the control group, the frequency actually went up over time. So the difference between these two treatment groups ends up being something like 70%. So that's a huge difference in terms of the treatments, bearing in mind that the two groups are the same, and the only difference that occurred here was the dietary intervention. Okay? So this represents very solid evidence that the treatment works. In kids with very severe forms of seizures, it typically doesn't produce a seizure-free state, but it markedly reduces the frequency of seizures overall. As happens there are no treatments that are exempt from what occurred in this study, no study ever shows that any patient uniformly responds to treatment and that there are no side effects. So 10 patients withdrew from dietary treatment before 3 months. 3 because the parents were unhappy about the restrictions. 2 because kids obviously behaviorally refused to comply with the diet. 1 had an increase in frequency of seizures, drowsiness, constipation, vomiting, and diarrhea. So a small percentage here you can see of patients are actually dropping out because of side effects of the treatment. And then when it comes to before I come to side effects, just to make the point again, that here you'll see in the two vertical columns, is this working? You'll see on the left here are the patients who achieve cutoff points. And here is a 90%, let me see if I can enlarge that for you a bit, a more than 90% reduction in the frequency of seizures. And so 7% in the dietary group versus none in the control group. So there are a small percentage of patients who have a more than 90% reduction in seizures. And when it comes to more than 50% reduction in seizures, again, big differences between the control group and the dietary group, 38 and 6. So you can see overall, if you take more than 50% reduction in seizures, then about 40% of patients are getting a halving or more of seizures in the dietary group, whereas that's most unlikely if you don't intervene with the diet in this group of kids. Now, when we're talking about side effects, the incidence of side effects, as always, there are side effects. But these are all things that can be managed either with changes in the diet or, in some instances, a pharmacological intervention. But largely, the dietitian will try and modify the diet to contain these. But things like vomiting, diarrhea, and constipation. Okay, so that was a really important study scientifically in proving that something which has been used for more than 100 years actually scientifically works. This is not just opinion, this is science. And then I wanted to show you, and we're probably running out of time, as a spin-off of this study, they went and looked at the two treatments, i.e., in terms of the diet, the medium chain and the classical ketogenic diets, medium chain triglyceride intervention arm. And really, the take-home message was that there was no difference here in terms of efficacy. So one can use one or the other. There's no scientific evidence that the one is more effective in reducing seizures than the other. Okay, And then, in the interest of time, I'll just skip over that one. But then, very recently, we've been using the modified Atkins diet for some while now. And I think this arose at Johns Hopkins when they discovered that kids and families who are waiting to be counseled and to go onto the ketogenic diet elected to try the Atkins diet, and it was realized that it appeared to be working. And so gradually there's been an impetus to use the Atkins diet, which is really easier to implement, especially for teenagers and adults. And so the diet has been, the classical Atkins diet has been modified in order to produce ketosis. And a couple of months ago, in March of this year, this important study was published. And in fact, it was published by a group from India who have used a very similar method to that which I've just shown you. So they again took a bunch of kids, did a randomized trial where half the kids were randomized to the modified Atkins diet, and the other half were randomized to continuing their usual medications without any change in medication. You'll see this happen quite recently here the study was done very recently in 2009 and 2011. These were again children, but we are using this diet in adults, and there's no particular reason to think that one can't use this diet in adults or teenagers. But the ages in which this study was performed was, you'll see here, between the ages of 2 and 14 years. And again, these were kids who were having seizures very frequently, at least 7 per week or daily seizures. The method was otherwise identical to that study which I've just shown you, so I'm not going to take you through all of that. Again, parents and families were asked to check ketones in the urine, baseline monitoring period of 4 weeks to check the seizure frequency, the baseline seizure frequency. And then the kids randomized to dietary intervention were started on the Atkins diet, and the other half just continued on their medications. And this was done, what's quite neat about this is that it was done on an outpatient basis, so it makes the diet quite easy to implement. And then I just wanted to take you to the results, which were, just to make the point again, was that these kids, very similar to that study that I've just shown you, consisted of implementing this treatment in groups of kids who had the most severe forms of epilepsy. And you'll notice here again, there are kids here with Lennox-Gastaut syndrome, West syndrome, myoclonic astatic epilepsy, and those where there's a structural lesion in the brain producing seizures that are very difficult to manage with medications. We've got 10 minutes. Good. Okay. So here is the, so in a study done in a very similar way to the one that I've just shown you, the seizure outcome in the two groups was as follows. So here they've again tabulated the results for us, and you'll see on the left is the dietary group, and on the right is the control group. Okay. Again, outcome is at 3 months. Ethically, you can't continue the study for longer. There's no particular reason to think that the efficacy of this diet wanes over time. And all of the observational data that's been accrued in the world suggests that once you get a beneficial effect from the diet, it's sustained. Nobody's observing patients where when someone responds to the diet, that there's suddenly, after time, a diminishing efficacy. So, and then you'll see on the left here, in fact, let me just enlarge this even more. On the left here are the mean percentages of seizures as compared to the baseline. So the way in which they measured the outcome was identical to the one which I've just shown you earlier. And on the left, the dietary group, you'll see here that's 59%. So the baseline would represent 100%. So the frequency has diminished, and at 3 months it's 59% of baseline. Whereas in the control group, it's virtually the same as it was at baseline. So again, big difference of about nearly 40% between the two treatment arms in terms of mean seizure frequency, in other words, average seizure frequencies. So again, a marked reduction and very, very solid evidence that the treatment works. This is not hocus pocus, because there's no other way that one can explain these differences at 3 months. And then if one looks at median percentages of seizures, the problem with means sometimes is if you have a group of kids and they're having daily seizures, but one each day, and there's one child who has 100 seizures per day, they're going to sway the results hugely. So in a scientific sense, when we're looking at seizure outcomes, we also look at medians, which means that half the numbers are above that and half are below that. And so it's quite a good way of checking that this difference is not being influenced just by a small number of kids. And you'll see here, in fact, the result is even more impressive, 30%, 37% of baseline, and in the control arm, 100%, which means it's unchanged, not surprisingly, because there's been no intervention. And then the proportion of children who have more than 90% reduction in seizures, 30% of patients. So that's quite that's a much bigger number than the other study that I showed you. But the important point here is a 20-odd% difference between the two arms, right? So again, very good evidence that where there are substantial reductions in seizures, these are occurring because of dietary intervention, right? And the reason it happens in the control arm is because, of course, there are some kids whose seizures are going to improve over time a bit, and there are going to be those that worsen over time. That's why we do studies like this where there's a control arm, so that if your kid happens to get better over time, sometimes it's just the natural history of the condition, right? So that's the beauty of doing a randomized controlled trial, is that where there are differences, you can attribute these to treatment and not to the natural history of the condition. And then if we look at the proportion of children with at least a halving of seizures, again, about half the patients overall have got a marked reduction in seizure frequency, more than 50% reduction in seizures, whereas in the control arm, only about 11 or 12%. Again, those represent the natural history of the epilepsies in those kids. The differences between those represents the effect of the intervention, i.e. the dietary intervention. So an important study, very important study, because we do use the modified Atkins diet, and important because it shows that in comparison to the stricter ketogenic diet, the modified Atkins diet appears to work as effectively and as Kath will tell you, sometimes easier to implement. And then in terms of adverse effects, like all studies, we always look at this. And again, you'll see the biggest problem here was constipation, which would obviously need to be managed in a dietary manner. And in occasion, some patients losing appetite, vomiting, and feeling lethargic. And all of that needs to be managed longer term with changes in the diet. So to summarize, what I've tried to show you is, as I said right at the outset, that this is not hocus pocus treatment. There are lots of medical conditions where people advocate all sorts of diets, where there's absolutely no science whatsoever, and a lot of this is just pseudoscience and people trying to sell things. In this instance, the diet works. The ketogenic diet clearly works, and so does the modified Atkins diet. Kath is going to, hopefully during the course of the day, tell you a little bit about why we use one versus the other. But I think at this point, I want to leave you with that take-home message. We're in the area of science here, and the diet has an important role to play alongside our other treatment modalities in managing kids with seizures, and especially so in kids and adults for that matter, where conventional treatments have failed, and hence this is an important treatment modality for us. And one other point to make, by the way, is that the advantage, of course, of the diets over and above pharmacological therapies is that both of them are long-term interventions, but dietary intervention has, although there are side effects, these are largely of a gastrointestinal nature. Pharmacological treatments, where there are side effects, are of a cognitive nature. And clearly, if you're thinking in terms of side effects, modifying gastrointestinal side effects with dietary changes is far more attractive than sometimes the cognitive side effects of medications.
In short, don't eat knickknacks. Not good for you. Dr. Butler, can I ask you, how long did you study for? On and off?
Well, probably about 13 years.
13 years. Let's give him a round of applause. Really, thank you very much. It's a real privilege to have people that have sown so much into their field of expertise to help others, and we're honored to have you guys here to share your wealth of knowledge. I was going to hang on to this, I thought about it, but I've got to give it to Dr. Butler. This is a gift. Thank you very much. We're going to break for a bit of a tea break now. There's some refreshments over on the